Hi, this is Brian Kim. I'm going to share with you this case of a patient who needed an IOL exchange due to a refractive miss. This is a patient who wanted about a -1.5, and then the patient ended up about a -2.5. I went back and analyzed everything and still couldn't figure out why this patient had a miss. And so we had a long discussion about our options, and we chose to replace this lens with a different lens. And this patient waited for surgery for about 4 months. And so I'm using a hypodermic needle. It's about a 25 gauge needle, and I'm going to basically cut through the epithelium at the level of my main keratoma incision and as well as at my paracentesis incisions. And using that needle helps me very carefully and precisely cut through the epithelium. And you can see it was fairly easy to open up the incisions, especially the paracentesis incisions. This one requires a little bit more effort going through the main incision, and it pops through, and I'm injecting some intracameral lidocaine. You can see this patient had a perfect overlap of the rhexis, and the case went really beautifully. So again, because I polish at the end of the case and try to get 360 degrees overlap, I feel this is advantageous for future IOL exchange. And so I'm going in with a hypodermic needle using a dispersive viscoelastic, injecting the dispersive viscoelastic into the anterior chamber first, and then trying to go underneath the anterior capsular rhexis edge and very carefully sweeping side to side, and then injecting some dispersive underneath the anterior capsule rim in order to separate the anterior and posterior capsules. You don't want to go too deep. You want to go about where the optic edge is, and you want to sweep side to side. You saw first I went bevel down, and then I switched to bevel up. I do think bevel up is a little bit easier to get underneath the anterior capsule. So once I opened it up, you see I switched the cannula, and I'm going underneath the anterior capsule edge, and I'm pushing the dispersive viscoelastic into the capsular fornix as far as I can circumferentially. You can see some of it has actually wrapped around, and it's now underneath the lens. You can see it is posterior to the lens optic. I'm going around 360 degrees, trying to sweep the anterior capsule free. And again, I'm pushing the viscoelastic into the capsular fornix. You want to avoid overfilling into the posterior capsular area because you can get a blow up. And see, I'm tilting the lens. You can see the lens is quite free. Again, this is about 4 months out, so the lens is not really super fibrosed into the bag. And I like to use the Sinskey. I like to get around the haptic. By getting around the haptic, I'm able to bend the haptic very easily, and it pulls out of the capsular fornix, and I'm able to lift it up into the anterior chamber. So with the Sinskey, I'm doing the same thing on the other side. I'm pulling the optic first towards me and then getting around the haptic. I don't know if you noticed it there. I'm going to play it again. I actually grabbed the capsule momentarily with the Sinskey hook. I recognized that and was able to release the capsule, but it's very important with these procedures to be very respectful of the capsule and be very mindful that your instruments, even though they're blunt, can snag the capsule. But thankfully, because I recognized it, I released it, and then I was able to, again, hook it up out of the bag and into the anterior chamber. And I'm just repositioning the lens so I can begin to cut it and then explant it. I'm going in with micro forceps and scissors. I use the closed teeth of the scissors to manipulate the optic so I can grasp the forceps on the left side more easily. I cut it all the way across. I'm still grasping that one half of the lens with the forceps, and then I'm switching on the right hand, grasping it with the other forceps, releasing it from the left side, pulling the lens piece out with the right hand, but I'm making sure that haptic doesn't go up and touch the cornea with my left hand forceps. And then now I'm going to grasp the other half of the lens at the corner there. And the haptic folds in nicely and the lens is out. So I'm injecting some cohesive viscoelastic into the bag. Again, I chose a lens power about a diopter or so less than the previous lens. The lens is going into the bag. I'm going to make sure that each haptic is off the optic. Go underneath the lens, rotating the optic 90 degrees clockwise, removing the viscoelastic from within the bag, remove the viscoelastic in the anterior chamber. You can see even before the surgery, there was perfect 360 degrees overlap, nice and symmetrical, removing the viscoelastic in the anterior chamber, and still I have very good overlap. I'm going to push BSS into the anterior chamber. I'm pushing BSS into the angle, make sure there's no dispersive viscoelastic hiding from me, because that's what causes those IOP spikes. And I come out with the INA handpiece, and then I hydrate my incisions. So you can see this is a patient who had an IOL exchange 4 months after the original surgery. I use a hypodermic needle to open up the epithelium. If you don't do that, you can actually cause an erosion in that area of the epithelium removal. So you want to just score the epithelium. This allows you to get into the incision, open up the corneal incisions, and then using dispersive viscoelastic on a needle, get underneath the anterior capsular rhexis rim, and then using the cannula and going around circumferentially 360 degrees, opening up and separating the anterior capsule off the optic. You continue to tease it so that the viscoelastic is separating not only the anterior lens capsule from the optic, but also the anterior capsule from the posterior capsule and the capsular fornix. Again, using dispersive viscoelastic to open up into the capsular fornix, trying not to overfill in the posterior capsular area to minimize any pressure on the posterior capsule. Prolapse the haptics up individually using a Sinskey hook, cutting the lens with microforceps and scissors, removing the lens, and then planting the lens. So I hope this was helpful to you, and I thank you for your attention.